Hello, everyone. Thank you so much for joining us today. We are excited to be hosting another edition of our COVID-19 and global health webinar discussion. My name is Rachel Vreeman. I'm a pediatrician and HIV researcher. I'm the director of the Arnhold Institute for Global Health at Mount Sinai and the chair of the Department of Global Health at the Mount Sinai School of Medicine here in New York. And it's really been our pleasure over the last year to try to host discussions that consider issues related to COVID and related to global health from a number of different perspectives. I'm excited to be able to have this particular discussion today that's focused on population health and global population health and what that looks like in the era of COVID-19. As people continue to join us, I would just note that we would welcome you to put any questions that you have in the Q&A box that you should see at the bottom of your screen. We'll have some time at the end of our hour together to look at those questions and to try to answer them with you. Now, it's my great pleasure to introduce Dr. Laura Ruhl, who is our guest for this webinar today. I'm going to tell you a little bit about her for a few minutes. And first of all, we thank her for joining us from Kenya today. Dr. Ruhl is the North American Executive Field Director for Empath. Empath stands for the Academic Model Providing Access to Healthcare. Dr. Ruhl co-leads Empath's Population Health Initiative. She received her medical degree from Indiana University. She completed residency training in both internal medicine and pediatrics at the University of Minnesota. She then spent 4 years with the Empath Partnership in Kenya, focused on maternal, newborn, and child health as the pediatric field director with the Empath Partnership. Then she completed a preventive medicine residency and a master's in public health at the University of North Carolina. Now, since 2017, she has been living in Eldoret, Kenya again, where she focuses on scaling up a population health initiative. Empath's population health work, which you're going to hear a lot more about today, aims to support the Ministry of Health in Kenya to improve access and quality of healthcare for the community by strengthening health systems, and that includes both efforts in facilities as well as interventions that are directed to improve the social determinants of health, such as poverty, lack of health insurance, and gender inequity in its communities. Furthermore, Dr. Ruhl has led research studies and work that we'll talk about, scaling up a mother-baby group intervention in Western Kenya called Chamas for Change, which tries to address the inequities that drive poor maternal, neonatal, and child health outcomes. So we'll talk much more about this. Again, I'm really delighted to have Dr. Laura Ruhl as the guest for our monthly COVID-19 and global health webinar. I've known Laura for a long time, so my apologies if I slip into referring to her as Laura rather than Dr. Ruhl. No disrespect is intended, of course, but we're mostly used to chatting in less formal settings, I would say. Nonetheless, we're really excited to talk today about the ways in which global population health delivery has been evolving, both over the last few years in this partnership in Kenya, but then also specifically as a result of COVID-19 and what that looks like for this partnership in Kenya right now. So, Dr. Ruhl, could you start with giving us a bit of an overview about Empath and what the Empath partnership is, especially as we may have some listeners who are not as familiar with this consortium. And then after you kind of talk about what Empath is briefly, I'd love to hear your description about what population health means. I think that's a population health, public health. We're hearing about these terms more and more, especially as we wrestle with a pandemic and lots of public health questions. But I'd love to hear kind of your definition about what Empath is, what it means to be in population health, and perhaps a bit about what this population health model that you've been working on looks like.
Great. Thank you for the kind introduction. Just let me know if you can't hear me, but
First, great right now.
Well, thank you. Empath stands for the Academic Model Providing Access to Healthcare. And it's a collaboration between Moi University, Moi Teaching and Referral Hospital, and then currently 14 North American universities that make up a consortium that partners with Moi University and Moi Teaching and Referral Hospital. And really, this collaboration embraces the tripartite mission of care, education, and research, but we always say that we're leading with care. So if we just break down those three pieces, the education program really focuses on bilateral exchange between the different fields that are a part of the collaboration, like internal medicine or pediatrics. The research program focuses on a counterpart relationships that investigate and study questions that are responsive to the local needs of the population here in Western Kenya. And then finally, and I think most importantly, the care program strives to partner with the Ministry of Health to improve both the access and quality of care. Under this Empath Care umbrella, we also have the Empath Care Delivery System, which largely focuses on HIV and delivery of chronic disease care here in Western Kenya. So to go to your question about population health and what it means here at Empath, really it's our comprehensive vision for our Empath Care program. And we describe it with three pillars. First, we really focus on improving access and quality of care within the public Ministry of Health. And so this largely focuses on health system strengthening because we're working alongside the Ministry of Health to improve care throughout the many different counties here in Kenya. Our second pillar focuses on the economic resilience and empowerment of our communities. And so really we're addressing the social determinants of health, such as poverty, gender inequality, food security. I think we're going to talk more about this today. Mm-hmm. And finally, we focus on increasing health insurance uptake. This is to both finance the health system as well as reduce the individual financial burden of having increased health needs for each family. And so we put these three pillars together to really aim to improve the health of an entire population by providing a comprehensive health system that meets their specific needs.
Great. Thank you. And I'm very aware as we talk about this model that in many ways you and I here today talking about this is not reflective of what the model looks like overall. And I'm really sensitive to that here we are, two white American women discussing this, and that's actually not at all what this partnership looks like. And I'm sorry that we don't have your Kenyan counterpart or one of our Kenyan partners with this today, but I wanted to mention that, I think as you describe the fact that this is this very specific partnership with the medical school in Kenya, with the teaching and referral hospital. It's very much, at the leadership and the welcome of those institutions, and that we've been at this for a long time. So just kind of, wanting to point out in that way that we're not a good reflection of what this partnership looks like in some ways, but yet I'm really glad that we do have the opportunity to talk about a bit more some of the work that we're doing. And we have been fortunate enough with this webinar series to have a number of leaders from Empath and from some of our other global partnerships discussing with us. I guess along those lines, in our group at the Arnhold Institute for Global Health, we are really dedicated to this idea of how do we decolonize global health? What does it look like to really pursue global health efforts with health equity for the people that we are trying to serve, with equity built into our global partnerships? And I would love to hear from your perspective how you've seen the values of the Empath partnership promote equity and try to reduce some of these power and privilege imbalances that we have historically seen in global health. I think it speaks to the unique model and how Empath has been trying to operate as well.
Thanks, Rachel. This is such an important question. I think in a way, Empath's organizational structure was set up with the very intention before the phrase decolonizing global health was even coined. First, Empath is a collaboration. It's not an organization. And I think that's sometimes hard for people to grasp. It can get very complex to understand, but any program or study must reside in one of the parent institutions. And so usually this is either Moi University, Moi Teaching Referral Hospital, or any one of the North American institutions. And we're soon to be joined by a European institution, so I'm going to have to start changing the way I explain this. with all the work that's happening in Kenya, it must be led by either Moi University or Moi Teaching and Referral Hospital. So no North American institution leads the work that's happening here in Kenya on the ground. It's a Kenyan lead with one of those Kenyan institutions as the primary lead for this work. And I think by ensuring the leadership and the financing are controlled by Kenyan institutions, Empath has built systems that support Kenyan leadership. I think we can see these successes in many ways. Kenyans are now able to attract their own funding. They've been successful with both NIH funding, MRC funding, and other research and donor foundation donors funding without any North American collaborators' assistance. In addition, we see that Moi University and Moi Teaching Referral Hospital are able to meet the stringent financial requirements put in place by the granting bodies. And then I think it really helps in how we implement our projects is that Kenyan staff are being overseen by Kenyan leaders, not by North American collaborators. And really the North American collaborators are operating as partners and technical advisors. Second, Empath, as I mentioned earlier, requires a commitment to bilateral exchange and counterpart relationships. By gaining the opportunity for each institution's students to learn in Kenya, those institutions must also provide the opportunity for Kenyan learners to go to the US and learn there. And so it truly is a bilateral exchange program. And then finally, Empath aims to build long-term capacity in Kenyan leaders. And a good example, I think, of this is our PEPFAR funding for the HIV program. In 2012, the prime institution was originally Indiana University, but it switched to be Moi Teaching and Referral Hospital. And these are huge multi-million-dollar grants. This isn't obviously financially beneficial to Indiana University, but it was seen as a huge success because really it meant that Moi Teaching and Referral Hospital had the capacity to manage such a large grant and program. And really it's become known throughout East Africa as the largest HIV program run by a local institution. And so I think all of these principles help build a foundation that aims to decolonize global health. And I do say this, Rachel, with knowing that you have to be honest with yourself, and every day we have individual conflicts that are a result of the power that privilege can create. But the system has been set up to reduce these conflicts and to teach learners how to collaborate as a visitor, though of course we're not successful all the time.
Sure, sure. No, I appreciate that. And I think, yeah, I think that's a really helpful overview of how these, how the principles and values that we're trying to embody together get structured into the organization in a way that hopefully does then provide a kind of a systemic, in a way of trying to counter what is otherwise a systemic problem of racism, of white supremacy, of power and privilege imbalances, and in these ways that can creep in and emerge in all these little ways as well. So I think it is a really interesting organizational structure, and appreciate how you've kind of walked through different pieces of it that way. That's really helpful. So I appreciate it. I've kind of forced you to give us, I guess, kind of an overview of like trying to understand what this partnership looks like and what the principles are, kind of where it's built. So I'd love to move to this question of talking about how things have evolved over the last year. You know, yeah, as you know, it was almost exactly a year ago that I was last in Kenya, and it was right around this time that, you know, that I believe, you know, you and others of the North Americans who are, you know, based full-time in Kenya or there long-term had to leave, and we saw, you know, across the world, of course, these, you know, massive changes start to happen with lockdowns and travel being stopped, and of course, you know, this COVID disease spreading so rapidly. So can you tell us, what has this looked like over the last year? How have things evolved over the last year in Kenya? How has work progressed or not progressed, and then kind of coming to where, I know it's a big question, but you know, coming to where we are today in terms of what the situation is for Kenya right now?
Yeah, it's been quite a year, and when I stop and think about that, it's been a year. It's scary to think kind of how quickly a year has gone, but how hard of a year it's been for everyone.
Yeah.
Um, so I'll start with the current situation. Currently, were about 586 new COVID cases in Kenya over the past 4 days, and then on the Moi teaching and referral wards, we are seeing about 5 to 10 patients each day on the wards. So numbers are currently pretty low from where they have been in the past, and our positivity rate is about 4.9%, which is a slowly increasing number. It was at closer to 2% when we first arrived here a month ago. Officially in Kenya, about 1,827 people have died of COVID-19, but we know that the actual mortality is likely much higher since not everyone is getting a positive COVID test and not everyone is dying in the health system, but are dying in the community. Um, the most recent peak here in Kenya was in November, and it came really quickly and it also left really quickly, but had a devastating impact. The mortality rate was low when you look at it worldwide, but frontline health workers were disproportionately affected, and we saw these losses here at Moi Teaching and Referral Hospital with close faculty here that unfortunately succumbed to COVID-19. And it's really affected people's morale and ability to focus on both clinical care and their research and programmatic work. Because of this, we're seeing that Kenya's nurses and clinical officers have been on strike for the past 2 months. And the reason they're on strike is because they don't have access to good protective equipment. And then they also don't have personal health insurance that actually covers for COVID-19 because there's like an exception clause in their coverage. And as a result of this, we're seeing that access to healthcare is really diminished for anything out in the counties. So the referral hospital is open, but the health facilities and county hospitals are either functioning at a minimal capacity or not open at all. And then I think the most severe impact that we're seeing is much upstream when we look at the economic and social hardships that Kenyans are suffering. Without tourism, with school being closed for a year here in Kenya, and then really a lockdown on movement between counties, the impact of worsening poverty, increasing mental health problems, and worsening food insecurity has really been apparent. Despite that impact, I think it's important to say that life in Kenya continues much in the way, if you're a visitor, in the way it usually does. And I think the reason for this is because Kenyans don't have the privilege to be able to work from home and to isolate as some people do in the US. So I think now if we go back to like, how did this all begin in March? You know, from my own personal perspective, most of pretty much every North American institution required the learners and the faculty to return to their home institutions, which really brought a lot of mixed emotions. Everyone was scared at the beginning of the pandemic, and so wanted to be near family, but also it didn't feel good to be leaving who we consider our family here and our friends here. No one had any idea how the pandemic would kind of play out in sub-Saharan Africa and in low resource countries. So once we got back to Indiana, you know, a lot of our focus shifted on how can we support Kenya during the pandemic. And this is hard when you're really far away because Kenyans were really consumed by getting the work done here. And so communication was not the priority. And so really a lot of our work focused on how can we find funding for Kenyans to be able to use. And so writing grants to support COVID and then starting to procure PPE and UVC machines to decontaminate PPE. As well as supplies such as pulse oximeters and such. My colleagues, Keitra and Kelly, Shamim, Ali, Mercy Karanay, and Kritika Patel also organized a COVID-19 lecture series that had really high uptake within the university and the teaching hospital. And then, by June, July, the pandemic was slower to pick up here because the lockdowns were so severe. And so projects began opening up again and things began happening. And it wasn't until in November that we began to see like a really big surge, though it was kind of slowly progressing between July and November.
Sure, sure. I know that a lot of your work sort of pre-pandemic and then also in things now has focused around some of the key elements of community health and what it looks like to provide health services and supportive and preventive health services to mothers, babies, kind of the how we help families in that phase of keeping them healthy up front and moving forward. And of course, I'm struck by the certain things that we hear about in terms of thinking about community healthcare, which become really critical when we're considering an infectious disease outbreak like this in terms of tracing and what happens in the community. And I'd love to hear from you sort of how you've seen what you're trying to do in community health in Kenya with your partners, how that has, I guess, been able to evolve or not, or kind of what pieces of that have been useful still in the middle of the pandemic. I guess too, with it, where you see that headed.
Yeah, I mean, my bias is that I think community healthcare needs to start by reaching people in their homes. And I don't think we're quite as good at doing this in the US as we are in Kenya. And so in Kenya, we've been fortunate that there is a large kind of human resource of community health workers. In Kenya, we call them community health volunteers because they're actually an informal workforce and not directly paid by the government. But these are the people that are most connected to people in their communities and help liaise people from their home to the health facilities. And so they're really truly the frontline healthcare workers for Kenya. And I think in ideal circumstances, these would be the people that really kind of led the health messaging for the pandemic, as well as would lead the contact tracing for COVID-19 here in Kenya. Unfortunately, without reliable PPE and without an ability to immediately move to online communication or voice communication, community health workers weren't immediately incorporated in the pandemic preparedness kind of work. And of course, they are an informal workforce, and so they weren't ready to put themselves at risk if they're not first compensated, but also protected with the right equipment. And so I do think there are some countries that were able to mobilize their community health worker workforce to kind of use them to successfully combat the pandemic. But I'd say here in Kenya, it was, in my opinion, and I'd be interested to have this conversation with my Kenyan colleagues, but I do think it was a missed opportunity.
Mm-hmm. It's interesting. We have a faculty member in our department at Mount Sinai who's also participated in the webinar with us, named Dr. Madeline Ballard, who helps to lead a coalition of organizations that support community health workers globally. Mm-hmm. And we've had the privilege of having not only a community health worker from one of those programs, but a few others from the programs. And it seems like again and again, globally, and they've been trying to do advocacy around this. Just as you're saying, the community health workers are not being counted in the numbers for PPE being needed, for a country. Mm-hmm. They're despite the fact that they have this potential to really be the most integrated with contact tracing, with knowing where risks are and these things, the struggle around both appropriately keeping them safe, keeping them supported financially in the ways that, of course, everybody needs to be, especially when things are so difficult economically as well. And really, I guess I would think of like integrating into the health strategy has been such a challenge in different ways. So I mean, I think we hear different stories from different countries or and groups where, I think some places, of course, are doing this really effectively, and others were still really struggling around it as well. But I think it's such an important consideration and something that, when I mean, of course, rightly in the middle of this pandemic, many of us, especially as Americans, have gotten very focused on hospital beds and ventilators and what's happening at that level of the healthcare system. But it is such a critical part of it as well to consider what's happening in people's homes and where care can be provided there, and we move forward with that. I'd like to ask you about another aspect of community health in which, I know you've been engaged for quite some time, and I know too that this model has had to shift a bit in this pandemic time, but I'd love it if you could talk a bit and explain a bit how the concept of these Chamas for change, these group efforts for providing care, education, and also financial stability and what that looks like for mothers, babies, has looked like in Kenya. And I guess if you could kind of describe kind of what that has looked like and how it's been effective in the past, and then also what you're seeing in this current era in terms of what we can and cannot do with that with our COVID concerns and where that's headed. But I think as a model, it's such an interesting one, and I'd love to let you talk about that a bit more and kind of what that looks like.
Great, I would love to, as this program is near and dear to my heart. It's kind of what I started very early on in Empath with my two closest friends and colleagues, Dr. Astrid Christopherson-Deb and Dr. Julia Songok, an OBGYN and a pediatrician. So first, Chamas is a Swahili word that means kind of a group. Our Chamas, we call it the program Chamas for Change, and our mother baby groups we call it Chama Cha Mama Toto, which essentially translates to mother baby groups. And these were framed on the premise that if you put women in a group and provide them peer support, health education, and some financial literacy, you will empower them to improve their own and their family's health. And so when we started the Chama program, I didn't quite understand how isolating pregnancy and early motherhood could feel. Now, 5 years later, I've had 3 kids, and I really do understand that even though you have people all around you, in your own personal experience, you can feel very isolated in pregnancy and motherhood. And so our Chamas are really trying to bring women together so that to reduce that isolation, and then to help them have the space to really feel accountable for their family's health needs, and then be able to have the kind of financial means and decision-making capacity to act on their family's needs. Because oftentimes in Kenya, women are not able to make health decisions alone in their family, and even if they wanted to, they don't have the financial means to do this. So our cluster randomized controlled trial, looking at the Chamas for Change model, where women come together twice a month as a group, talk about a health priority. They talk about a social priority, so it can be anywhere from kind of violence within homes to sex and pregnancy. And then they do a savings and loan program over a 2-hour period. And our RCT really demonstrated that this model can improve the uptake of delivering in a health facility. It can improve exclusive breastfeeding rates, and then really help to improve immunization rates within, and mainly the time within uptake of immunization by 1 year of age. And so, what did this look like pre-pandemic? I mean, I think it was, if you could imagine a group of pregnant women or of young mothers coming with their babies and kind of chatting and all crammed in together, and the kids kind of jumping on top of one another as people discuss different issues, and it could get pretty lively. I'm happy to say that the Chama program throughout the COVID-19 pandemic, though it did stop meeting for a period as we understood COVID-19 and understood the importance of social distancing and the impact of COVID-19 on pregnancy, we are continuing to run now. It
Mhm.
started up again midsummer in about July. We've been able to meet with social distancing, everyone in masks, sanitation. We've provided sanitation facilities at the beginning and end of each group. And women are really wanting to still come together. And so, though it looks different, they still have that peer support. And even when things were on lockdown, women continued the savings and loan program, using their phones and using a system to deliver their kind of savings to the point person, but not meeting as a group. And so it's really been encouraging to watch how these groups have really formed a bond, and it's helped carry them through the pandemic.
That's incredible. And I know, we've heard, as you know, that a lot of the work that I do is particularly related to families with children and adolescents who are living with HIV, and with our adolescents especially, we've heard so much how, there's been such a loss of income in so many families. The adolescents reported with themselves, but also others in their households losing jobs, losing income, so much food insecurity, where people are often reporting now that there are many days when they only have one meal, and other days of the week where even they don't have one meal at all for that day, and things that are just really dire in many ways. And I think at the same time too, the social isolation, and all the mental health challenges that creates, understandably so, of course, for so many of us, but especially with the anxiety and depression and just the kind of loss of joy in life that's created from being not only in such isolation, but then with such financial insecurity as well. And so it's in the face of all of that, and knowing that there's so many layers of that and how intense it's been, it's really so encouraging to hear that the women in your groups and these groups have found ways to continue to interact, whether through the phone texting options for saving money and staying in touch, but also even to come together as a group in that way. And of course, that's such a critical period for them, both in terms of the vulnerability of infants during that period, and for mothers as well, in all of that. So that just makes me really, really happy. I think that's beautiful to hear about. I guess along these lines, um, what other health impacts and social impacts have you been seeing and hearing from families at a community level as we think about the pandemic, and what that's looked like, whether it's ways in which care is being delayed or shifted, or things that are happening in homes that we maybe are not thinking about, that are critical for us to remember, thinking about community health moving forward too.
Yeah. I mean, I think we haven't yet seen the extent of the health impacts that are going to be secondary to the mortality from COVID-19, right? And the strike is only enhancing those. And so, right now, I think access to maternal child health care, women don't have a facility to deliver in right now. I mean, facilities are closed, and so they have to come to the referral hospital, which from kind of the area that we started the Chama program, it's 4 to 5 hour drive, right? And there are some health facilities that have very committed staff who are still opening for emergencies and providing care, but it's certainly you can't count on it. And so therefore, Kenyans are having to go to private facilities for emergencies, and really aren't able to get the care for their chronic diseases. And so I think, as we're seeing in the US, where everyone delayed their chronic care, we're going to begin to see late stage cancers,
Mhm.
the effects of uncontrolled hypertension and diabetes, and the many other kind of health complications that come from ignoring or not having access to a health system. which is essentially what's been happening in the last year. First, people were nervous to go to seek healthcare the same way they were in the US, and now they haven't had access because of strikes. And, you really can't fault the providers for being on strike because they're not safe to provide healthcare. Because they know that they're seeing patients with COVID-19, and they need to protect themselves and their families. And so it's a very complicated situation.
Yeah.
As far as the social impacts, I think that this is what's really most visible right now is even just on the local level. This is a country that thrives on tourism, and the tourism industry is just shut down. There's no international tourism. It has created a space for some national tourism where people are now able to afford to travel within their own country, which is actually a positive that I think you can point to from the pandemic. But overall, jobs due to the tourism industry have declined significantly, and that's had a huge effect. And even if we just look here in Eldoret, the Empath community, we at any one time could have 50 to 100 visitors here at IU House, right? And so we really supported the local economy here with the restaurants and the tourism, the small tourist operators that served our students and learners and faculty, and they're really suffering. And so it's really hard just to see on a day-to-day the people here in Eldoret. And then I think that we all are very aware of the mental health effects of the pandemic, the mental health effects of being isolated. And I think specifically to your population, most in your heart, Rachel, is the adolescent population. They've been out of school for a year now, and the mental health effects of being out of school and the stresses that they have towards needing to succeed at school, yet not being able to be in school, I think have really been significant. And we've seen the effects in this population in the US as well. When I was on the hospitalist wards and seeing kind of eating disorders increase and suicide attempts increase. And it's not being as well documented here in Kenya, but it's really, it's a huge problem.
Yeah, absolutely. Yeah, it's interesting is even just hearing this last week about in the United States among adolescents, the increases in both deaths, but also hospitalizations and ICU stays with adolescents who've had overdoses from different drugs, and some of that in suicide attempts, others with increased substance use related to the pandemic challenges as well. And in that way, I think there's just so many layers of that where we see that impact. I wanted to ask you for your thoughts. So when we look ahead, to Kenya, East Africa, and of course a lot of the countries globally, we're thinking, of course, about these questions of vaccines a lot. And again, I think it comes into the question of health equity and also how our community health systems work and so on in this. And I wondered if you could talk a little bit, both in terms of the specifics of, for Kenya in specific, what they're talking about with vaccine rollout, what's on the horizon there. Do you see the Empath Population Health Initiative playing a role in vaccine distribution at all? And I guess, with all of that, happy to have whatever thoughts you'd like to give about what our global vaccine equity challenges are, because those are very much, I think, in our minds also with this.
Yeah, I mean, I think this pandemic has demonstrated the huge inequities that exist between low resource and high resource countries, especially when you look at just in the early stages in procuring emergency PPE supplies and the increase in demand. And Kenya really was really low on the totem pole in being able to access quality PPE. And it took a long time to be able to get PPE, and there's still facilities that aren't getting it. And so I think when we look at the global rollout of the COVID vaccine, we're seeing these same inequities where it's those who countries who have the power and the money are accessing it first. And I have a lot of personal conflict because I was able to receive the vaccine before coming here to Kenya, and my Kenyan colleagues, they still don't have access to the vaccine, and so it brought a lot of conflict in knowing what was the right thing to do in returning, and certainly has made it so that I want to play more a larger role on the wards and putting myself in the front line than I normally would, because I did have the privilege to access the vaccine before my counterparts. Um, and so I think um, as far as your question to is population health going to play a role in the rollout of the Kenyan vaccine, we're hoping to receive the AstraZeneca vaccine here in Kenya in the next month. And it's really going to be focused on frontline health providers over the first 3 to 6 months of the rollout. Um, and it's going to be a national Ministry of Health program. And so it's going to be dictated by the national government, and even Moi Teaching and Referral Hospital can't provide specifics, even though they're a national referral hospital, and how the rollout's going to take place and when we're actually going to receive the vaccine. And so I think our goal at Empath and in the population health program is we're always supporting the county ministries of health. And we're really just here to support them once they tell us what their needs are. And right now, no one knows what their needs are. And so it gets difficult to know how to support a vaccine rollout without the details to be able to support it. So I think we would love to play a role, and even if that is just financing some of the vaccine rollout as population health, if a county can't do it in the way they need, or providing the rooms they need, or help providing staff. But it remains to be seen how we'll play a role.
Yeah. I think it's so, it's often been, of course, so frustrating, but also so clear throughout the last year and in this pandemic, how both global health is incredibly, I would say, like relevant and important, and yet also such a challenge in the sense that, I think, with this pandemic, I think it's impossible to ignore the fact that we're not healthy unless we're all healthy in this. I mean, sure, people try to ignore this and actively, the systems are set up in ways that really essentially make it almost impossible for all of us to be healthy, then that, certain populations are cut off from care and cut off from resources, and that's never been more clear. And I find it, of course, so both personally frustrating and also just intellectually frustrating that you would have, even in the questions of vaccines, the questions of PPE, that's just perpetuating these cycles where it's like we're just thinking about a very particular group, and that group that we've chosen to privilege and protect and get vaccines for and get PPE for, and that it's like, even if you're going to say like, okay, that's well and good, yes, everybody needs them, like focus on who you're supposed to take care of and protect, there's still this ultimate challenge that, like, again, like we're not healthy unless we're all healthy. Like we're an interconnected system, and we're never going to be done with this pandemic. Even if you don't want to do this out of, your values or the goodness of your heart, you might say these other things. Yeah. Like we're never going to be safe from this virus if there are still, places where the virus is spreading and mutating out of control, and those things. So just, I know there's just constant, both at an individual level and also, where we have the impact with systems, it's just such a challenge that way. But all of that, and my ranting aside, I guess it is, I think really critical to think about, what can we do, even though we're more limited perhaps than we want to be, and even though we see resources being directed in really inequitable ways, of course, to try to advocate against that, but also in these practical ways, how can we support specific, ministries of health activities to roll things out in that way. And I do think in that way, the kind of complementary focus on how do we also provide what's really needed for PPE and make sure that those systems are coming through make a lot of sense. Let me just note for our group here who are joined us, and again, thank you to everyone who's part of this conversation. Please feel free to type questions for Laura and or me, I guess, in the chat box. We'd love to take some questions as we look at this. So, Laura, I'd like to ask you kind of some big kind of policy and practice questions as we kind of close up this part of our time talking. So when we think about kind of the more near term, what do you think are the top priorities for low and middle income countries in particular for trying to stop the spread of this virus in the way that they can, recognizing that it is not like burden's not only on them, of course, and that in fact, of course, high income countries like the United States are in many ways have some of the greatest problems here. But what do you see as being critical priorities in the more kind of short to immediate term for low and middle income countries right now in the pandemic?
Yeah, so I think because people don't have the resources to prevent transmission within their homes, they can't isolate. They have one room, right? They can't go off and isolate themselves if they get sick, and they aren't able to stockpile food for days and isolate their family in their homes. There needs to be more emphasis placed on vaccinating the vulnerable populations over the next 6 months, and so I think. Um, with this healthcare crisis, with the strikes, really a focus needs to be placed on how are we going to protect our frontline healthcare workers so that our collapsed healthcare system can begin functioning again and begin providing care not just for COVID-19, but for everything else. And this can't happen unless a focus is placed on PPE for frontline healthcare workers and on the vaccine. And so I think before anything can be addressed in the community, the health system needs to be functioning for that community, and then secondly, a focus on the vulnerable populations, and so those most at risk to getting sick from COVID-19, getting them access to the vaccine, and trying to figure out ways to protect them, people in their homes, creative ways when someone does get sick with COVID-19, or more kind of quarantine support programs that, currently no one wants to quarantine at any quarantine facility because they're so inadequate in terms of comfort and food and basic security, that we need to be helping communities support the ability to protect their loved ones and vulnerable populations by helping provide these types of places.
Sure, absolutely. And I think in what you've described for us today, it is such a critical, like as we think about, the strikes among the nurses and the clinical officers, which are similar to physicians' assistants in certain ways in the United States system. As you've pointed out, it's one thing to keep the referral hospital operational, but there are all these impacts for, where might women deliver babies? Can you access a healthcare center at all that's not 4, 5, 6 hours away from where you live? That kind of access to healthcare, that's not just like, can you get to this hospital with the highest level of care, but all these ways in which we need healthcare access much closer to people's homes and even in their homes, and that way too, in terms of what's needed for a quarantine or what's needed to be able to stay safe in your home as well. We have a few interesting questions coming up. So one question here is related to, how do we ensure equity in the bidirectional exchange of students during COVID, which I think is one that I would imagine you've given some thought to as well. Yeah. It's sort of course, both Empath and what we've done in Empath over these years.
This is a great question, and one that we're still wrestling with, and I don't think we really have a good answer to, because I think that students in North America are going to have access to the vaccine before if we're talking health students or medical students, nursing students, prior to those in Kenya. And is that if we know that we can't yet provide that bidirectional relationship where we can't invite students and residents over to the US because they don't yet have access to the vaccine, can we re-engage our learners here?
Mhm.
And we didn't know the answer to this question, and so we really just took it to Moy University and we said, like, what do you all want? Because we don't feel good about this, and we only want to bring our learners back um, as it feels good to you and as it feels right to both, all the different collaborators. And so what we essentially decided right now is that medical students are not yet allowed to start rotations again, and we're not going to likely readdress it until the summer.
Mhm.
Um, but that medical residents who have had training in global health, they would like to welcome them back to the ward,
Mhm.
um, to help provide kind of medical care, medical education. Specifically, they're actually relieved that they've been vaccinated because then they won't contribute to transmission. And
Mhm.
they've required that they be vaccinated to come. And so so we are going to continue forth with the medical resident rotations, and we're trying to look at how we can begin to have Kenyan residents be able to re-engage. Their rotation wouldn't happen till the fall, so luckily we have some time, and we're
Sure.
hoping that we can have the vaccine available so that we can um, restart those rotations as well.
Sure. Sure. And it certainly makes sense that of course, if we are able to achieve more equitable access to the vaccinations for the healthcare providers in that way, that would potentially make a big difference in the ability to
Yeah.
open that up as well. So we're so glad that's on the horizon. Another question here, which is I think a great one and interesting, is: are anthropologists engaged with your work in Kenya? Have there been any cultural barriers that you faced to doing your work overseas? I feel like we could have a whole probably at least an hour, probably more, discussion about cultural barriers and ways and things we've learned about that over the years as well. But I'd love to hear um, a, a quickish response, I guess, recognizing it's probably not an adequate one to answer such an important question.
Yeah, I think it would be lovely to have anthropologists more involved here. We have collaborators in engineering, but in the liberal arts, we haven't had as many university collaborations. And Moy University has a main campus of undergraduates and graduates in anthropology and other liberal arts studies. And I do think that it's a huge opportunity. My first trip to Kenya was in an anthropology program with the St. Lawrence University program. And I think Katrin Kelly's first experience was with that as well. And the whole program focused on looking at the cultural differences as you did your kind of first international study abroad trip. And so I think it really could help our learners and Kenyan learners as they go overseas digest and analyze and discuss their experiences if we had more anthropologists involved. I will say that Dr. Astrid Christopherson Deb is a medical anthropologist as well as an OB/GYN, and she really helped us inform the Chamas for Change program um, with an anthropology focus. And she came at it from a very different lens, and it really helped us really think more about equity issues and gender issues, and really looking at it from a woman's perspective, a Kenyan woman's perspective. As far as the cultural barriers, they are countless. I think every day I stick my foot in my mouth in some way or another with my Kenyan colleagues. But what's really amazing about the Empath collaboration is we now understand each other's cultures quite well. And so when I screw up or do something culturally inappropriate, like today I texted a registrar and didn't greet them before I asked my question, right? That's a big deal in Kenya. People really have understand one another, where one another's coming from in Empath, and I think are pretty forgiving of it. And so it's not very common that we have just huge um, mishaps due to people not understanding each one another's culture. But it
Sure,
does happen every day.
of course. Of course. It's interesting too, even I think with the anthropology question, I think, it's one of the things, and as you know, and for the group, I've also worked in the Empath partnership for a long time. And one of the things that I have really valued and continue to respect and love about this model is that it has over the years grown from not just being this partnership between two medical schools, but trying to really engage in a broader partnerships, whether that's with other health sciences in terms of nursing or dentistry or physical therapy, but also, with the business school and journalism students and things. And I think while the social sciences partnerships could certainly, continue to grow, and we'd really welcome that, there have been a number of engagements over the years. I think with my own team, I know that we had a series of projects where we had actually an anthropologist from Indiana University who partnered very closely with two anthropologists from Moy University's main campus, essentially their undergraduate campus, the department. And we did interviews and qualitative work in the community together that ultimately led to the creation of films that were depicting stories of adolescents living with HIV and wrestling with stigma. But the stories in those films and the themes and what was moved forward was from this collaborative anthropology team, really. And even actually the making of those films was done through a partnership between media studies students at Moy University, who were the ones who, were doing the filming and the sound and editing, and partnered with expertise from Indiana University as well. So I think there have been
you're right.
in which, across different efforts, there have been parts of this, but completely, I would agree and support our broader social sciences engagement also. There's maybe we have time for one more question. Here is another big one, if you're willing to try to tackle it. In that the question says, Empath's rigorous academic partnerships are surely a reason for its success in Kenya. What do you see as drivers or barriers to engaging US healthcare systems to advance population health work globally as well? So maybe a question of what has worked for Empath, do you think? What is the secret sauce in that? But with that, what makes it difficult for US health systems to engage in these kinds of efforts typically?
Yeah, I think global health requires kind of collaboration and mutual respect, and collaboration is not easy. And once you put in different time zones and different within health systems, we all have different kind of job descriptions or what expectations of what we're supposed to accomplish. And so Indiana expects one thing of me, but Moy University expects something different of my Kenyan colleagues. And in order to try and bring those together and collaborate and both get what we need out of the collaboration and the relationship, it's complicated. And I'd say that most of the time it's spent figuring out how to collaborate with one another and figuring out our relationships. And by spending so much time on those areas, we are able to succeed in our different projects. And so I think health systems collaborating with other health systems makes it even harder. I look at right now, Moy University is working to create our Moy teaching referral. Moy University and Indiana University are trying to develop our memorandum of understanding. And it's 3 years in the working on revising the MOU that was once there. And so when you're talking about collaborating between health systems, there are so many bureaucracies and moving pieces that make it very difficult. And when you're really focusing on it being a collaboration, I think distilling it down to the relationships is the most important piece. So I'm not sure if that makes sense. But.
Absolutely. I think for me, it makes sense. I think it is this really, as you've said, partnerships being such a critical part of that, and that it's not just although our individual level partnerships are critical in this, that institutional partnerships and systems partnerships are what make it possible, but of course also are, to form those is incredibly complex, and to maintain them is incredibly complex that way too. All right, my final question that I like to ask our guests, and you can answer this really short, with just a few words if you want, but what is giving you hope right now?
You know, I think that it's really looking at the resilience that we all have in our lives as humans. And I think, I get to see this every day in my kids and how they're handling the pandemic. And though they're having tough times, they're just incredibly resilient, and they're still happy, and they're still thriving. And when I come back to Kenya and see Kenyans who are really struggling, um, are, they've faced one crisis after another, and yet they're so resilient, and they get back up on their feet, and they hold what is most important close to them, their families, their communities, and focus on their basic needs, and not on all the kind of distractions in our everyday that can really affect our well-being. And so I think it's just watching how resilient humans can be is what brings me the most hope.
Thank you. Thank you so much for that. And thank you so much for your time today, as well as all the work that you're doing right now. For everyone who's joined us, the recording of this will be posted on our YouTube channel within about 24 hours. Again, thank you for joining us. And we would encourage people to join us next month in March as well. We're really excited for International Women's Day to have a webinar session that's featuring stories from several women who are global health leaders from a number of different countries. And I think it should be a really lovely session to hear these incredible women and their stories of global health leadership. So we're looking forward to that for March for International Women's Day as well. Again, thank you so much, Dr. Laura Ruhl, and everyone who's joined us. Take care.
Thank you.